Now we need to move to a very critical topic, and Abdelrahman is not the first time. He came here and he talked to us last in July, and when he talked, and I was very impressed, and I said to him, he's a real doctor. And I said to me, what do you mean by a real doctor? Because he was talking about sustainability, Millennium Development Goals. That's not a criticism for doctors, but he's so knowledgeable about the real issues. You have to go beyond being a physician and treating people. As you said last time, Mayada, health is not about just treating patients, it's about well-being, about being a human person in terms of... So I will go quickly, but he's going to talk to us about a very important issue in Sudan about health economics, which is a part of the economics departments. In economic department, you have some people who actually study health economics. But most importantly, there's lots of claims. Some people, they say, any person in Sudan, how much poor he is, he or she can still get treatment. Or the system is working. The government claims that all the time. And I remember I asked him earlier the question from the Facebook, can it be free? And there is some other people, I have spoken to some people, they say, yes, it is working. I asked people from MEKEI, and they said, yes, it's working. I go and I get treatment. If I need to go to a consultant, my insurance, Shekan, whatever it is, it pays for me. So there is really loss. So the question we want him really during his presentation to address for us, if you can somehow make that very clear during your presentation, is it working or is it not working? I know you're going to make us a very good presentation, but really we want to get to that point. Is it working or not working? So people in Sudan, they can learn lessons how it can make work. So Abdelrahman, the floor is yours, okay?
Assalamu alaikum wa rahmatullah wa barakatuh. My name is Abdelrahman Omer. I'm a radiology registrar, diagnostic and intervention at Newcastle University Hospitals. I had the pleasure to work as a health economist at the Federal Ministry of Health in 2012, where I worked with people who look after the finance and economics in Sudan, whether it's National Health Insurance Fund or the World Bank or other stakeholders as well. And I don't think even 10 minutes will scratch the surface of health economics in Sudan. So I'm just gonna give a glimpse of what's going on. And maybe we'll have more time in the question and answer to answer most of the things people gonna raise. So I always when I look at economics, finance, money in general, it's worthless without a purpose. So we need to look at what's the purpose of throwing money at the health system. The purpose, I think it's, the money we're going to throw in the health system is not our money, like me or Professor Allah money. It's the money of the people, money of the Sudanese people. So what's their expectation of the health system? What's the Sudanese people expectation of the health system? So I'm just going to draw on the Sudanese culture, not here to teach you about it, but Sudanese culture is renowned for its compassionate nature. We are known for hospitality. We are known for the extended social network and support that we have. You see, the couples don't look after their children only, they look after the elders, they look after the extended family. So we have this nature. And you can easily draw from that. We need a health system that serves all. So that's, I think, put the privatization to rest. So we're going to go to a private system. I don't think we're going to do the same mistake that the United States is doing. But we have a technical term for that, which is universal health coverage. So for universal health coverage, universal health coverage is one of the sustainable development goals that have been adopted by United Nations Summit in 2015 by the world leaders. So everyone agrees on it. But for me and for many of my fellow youth, for many of the Sudanese citizens, it's not just a goal. It's not just a 3.8 goal under the health sustainable development goals. It's a moral responsibility. It's our moral responsibility as academics, as policymakers, as stakeholders. It's our moral responsibility for the Sudanese citizen. And with that in mind, I wanted to paint this picture with that in mind before diving into the numbers and paragraphs and what we need to do. We need to keep that in mind. We have to create a system that serves all. So when putting a health finance policy, you need to look at two processes. Okay, you need to look at linear process, which is on my right-hand side, and you need to look at a dimensional process. So a linear process, there's a lot in health economics and finance, but these two things, I need to paint it really good before I go to the next slide. So the linear process, revenue raising, from where we get the money, okay? Budget, is it tax, is it trades, okay? And then how we pool it, who do we give it? The National Health Insurance, the State Ministry of Health, military, police, how we're gonna pool the money? And then how we're gonna purchase the service, how we're gonna buy the service? Are we gonna buy it from private sector, state, or primary, secondary? You need to know that as well in any health finance policy making. This is one dimension, a linear one. The other one on my right hand, it's a cubicle. It's there is 3 axes on it, okay? First, are we gonna cover everyone? We made this point earlier, we're gonna cover everyone. So that's the percentage of the people population coverage. The people population coverage now is ranging between 38 to 42% of the total population, and only targeting the formal sector. So someone who's in no informal sector, not working in Shekan, not working in one of the governmental institution, will not have access unless he pay a tariff. And that's not compulsory, that's actually depend on the patient. That's a decision of the person. So we don't have total coverage now, first. Second, the axis of what services we're covering, okay? Are we covering primary only, covering secondary, or we're going to cover everything, even the transplant, the lung transplant, and the fancy stuff, as we call it here. Some of the stuff not even covered in the UK system. So we need to know that. The other thing is, how much we're gonna ask the patient to pay. Are we gonna ask him to pay 20%, like they do in medicine, medical, pharmaceutical stuff? Are we gonna ask the patient to pay nothing, like we do in investigation, like ultrasound, CTs? That's what happened now in Sudan, National Health Insurance Fund. So this dimension also, we need to keep it in mind while making health financial policies. So now we're going to go to the statistics. If I have time, I will mention the numbers, like how much we spend on the system in the question and answer. But putting it on percentage, I thought will give us a better idea. So here, the public sources, the government with all institutions, only contribute 22% of the total health expenditure. Okay. Here I say private sources. That's by the way government statistics. I'm not making it. So it's a joint. I worked at the National Health Accounts, which was done 2000. So it's a little bit outdated. 2012, and the report was struck in 2014. It's a joint between World Bank, WHO, and the government. So that's everyone agree on these statistics. So the people pay directly from their pockets 73% of the total health expenditure. And that's alarming, because if you spend, statistically, literature says, if you spend more than 20%, the people pay more than 20% of the total health coverage, you can easily shift someone who middle class, when got a like, for example, a massive disease burden, like for example cancer, you can shift him from middle class to poverty easily. So that's alarming. We need to get that percentage down. Whatever policy we're striking, we need to get that percentage down. And the international contribution is very modest. It's 4.5 comparing to a neighboring country. For example, Kenya get more than a third of its total health expenditure coming from abroad. So we're not going to rely on that. We need to rely on our resources. So, and now this diagram is for what the people. So I've took the international donors. I've took the government pay. I'll get back at the end. I've took the international donors and the government contribution. That's what the people pay for the health for their health. Okay, so strikingly counterintuitive, we pay people pay 35% on primary health service. So the people will always. The problem is we don't look at the primary health service as an issue because most of our representative, most of the people who raise concern usually live in urban areas. So we always talk about hospitals, we talk about secondary and tertiary care. But actually, for many reasons, we need to strike the primary care services first. So the State Ministry of Health hospitals, which is regional hospital, not even like the tertiary hospital, we contribute 26. The big hospital, okay, tertiary hospital, only 8%. And the people always talk also about the private sector, the private clinic. We contribute only 50, people only pay 15% for the private sector, for the private offices of physicians. And the private sector taking all the money is only 2.5. So that's give you a perspective where to hit first when striking a health policy. Okay? So what's I've put that here as a so health financial policies have got we have a set. I think we need a set of policies targeting every stage at every level. Okay, but the main issue or the first phase or the first 3-4 policies that we need to do is policies that favor the primary health care. Okay, the problem is the primary health care budget is mixed with secondary and tertiary care budget. And when you get it mixed, the people who have more representation will live in urban area, will have more access to secondary and tertiary care. You will shift your budget to the secondary and tertiary care service. So first of all, we need this allocated budget straight away to primary health care services. Okay, and it's a set of 4 or 5 policies that we can do the shift. The most important of it is change the purchasing policy or how we buy the service. Okay, we need to change from fee for service, which is basically fee for service is meaning like if the patient comes, if he need an ultrasound, need a CT, and need his medication, you pay for each one individual. Okay, but a capitation with incentive, which is a different policy, will shift to a different kind of payment. The government now will give money upfront to percentage money upfront to primary health care services in rural areas to set up their primary health care service, okay, or their GP clinic or whatever, and will also change it's called behavioral economics. We change the behavior of the doctor from asking the patient, wait for the patient to come for him for ultrasound, for CT, for investigation, is actually for the doctors to go to the patient, to prevent him from coming to his clinic. Because with capitation, I'm giving you, for example, you've got in this catchment area, got 20,000 people living in your area, okay? I'm giving you the money, £25 for 20,000. That's the all money that I'm gonna give it to you, okay? I'll give you half of it to set the service up, and then I will give you incentive for how much you're doing. So if you're treating people at home, I'll give you more. If you're waiting for them, I'm not going to give you. So you change the paradigm, the shift of the doctors. This first. Also, it's incentivized the people to stay at rural areas because I'm giving money at primary care. I'm not giving it to the secondary and tertiary care. I think I'm up to my time, but the other one thing I'm going to mention is compulsory enrollment. And that's unified across literature. We need compulsory enrollment of the whole population. And I have a practical, if coming question, I actually have a practical approach. We've got the money allocated to the social and healthcare sector. We need to mobilize it to primary care, and we can easily now, with political decisions, to do a universal health coverage by the end of 2017. That's achievable. But for what? I'm going to discuss in the question and answer.
Thank you very much.
Thank you.
Thank you very much. The question before we came here, people have asked about. They said all the insurance in Sudan is for people who are working in companies or in government. Sorry. Yeah. What about the individuals? I don't work in government. How am I going to survive?
Okay. So the statistics of it, the coverage now is for 16.5 million millions. Okay, it's 4 million family. 1.8 million is actually covered by various. They are poor families. They don't pay themselves. It's an informal sector. But how we can that's total of 40%. How we can cover the 60%? That's the question. How to cover the informal sector, and that comes with the primary healthcare policy. And the other thing is to actually. We've got now budget allocated for the social support. It's about 80 million Sudanese pound. That's the new pound, which is 80 billions with the old one, okay? If we divide that on the rest of the families that living now in Sudan, it's gonna be, we're gonna pay 26 pound per month per family, okay? For the whole population that's not covered under the
Okay, Abdelrahman, just a question. This is the people keep asking this question.
Yeah.
If I'm not working in government or in university or anything, I have any problem and I have to be taken to actually the emergency, which doesn't exist, as Ahmed said.
Yeah.
What will happen to me? I would be treated or not?
You'll be treated for free.
For free?
No, for fee.
For fee,
If
yes.
you are not covered...
Even if I am diabetic, or have asthma or all these critical illnesses?
So critical illnesses, they say you are treated, okay?
No, don't worry, I know you're not the Ministry of Health. I'm just asking you. From your experience, and you've been in Sudan, if I am diabetic or asthmatic, you know the immediate care one. If I've fallen down on the street of Khartoum or anywhere in towns, if I've been taken to the hospital, I don't have this insurance with me, I will be treated?
That's
as far as you know.
Because I'm for, the last time I've been to Sudan,
yes.
Working in a hospital.
And you're very active in Sudan, yes?
4 years ago. 4 years ago, for example, in Khartoum, you get treated. But I'm not sure about the rural areas. That's why I can't give the whole perspective. They say emergency treatment is free.
Okay, tamam. Very quick question. Yes, quick. Yes, thank you very much. We'll come back. Yes.
Okay.
Ask him, yes, quickly, yes.
Talking about insurance, and it's been mentioned earlier, but is it affordable? I mean, if you come up with like insurance covering, I mean, how much is it going to cost per family? Dr. Alam mentioned as well. How much, according to your report? Like, I mean, and what does it cover? What does it cover? Because we never. I mean, I knew quite a few people work in the government or work in some companies, and it doesn't cover. Yes, an appointment with a consultant, but it doesn't cover like cancer treatment or dialysis or a lot of things. I mean, so many consultants are available only in Khartoum. Like if someone, an engineer, what does it mean?
So does it work or for people like what he said, affordability and so on? Just quickly, Abdelrahman.
Yeah, so the premium now is £40 per month. For the family, okay? Family usually of 5. The premium, I think the responsibility for the government now is to actually make the political commitment to cover the whole population, at least for the primary care services now, and shift the policies to incentivize the rural compared.
لكن عبد الرحمن sorry to interrupt you. I'm sorry والله لأنه عندنا ناس كانوا بيضحك. لما last time دكتورة ميادة قالت well today she mentioned the WHO والفحل قال the same thing. Is it not a right? Is it not my right to be treated if I am whatever this in respect? So, is it the government? Is that something is a choice for a government, or they must provide me with medical health at least if I am diabetic or asthmatic, whatever it is? Yeah. Is that not a right for people to have according to the WHO and the global, if you like, agreed principles of life? Is it not?
So I think I try to also cover that first is our culture. We can't come up with the system. We can't agree on the system unless it serves all. This is first. Second thing, access to health is the fundamental human rights.
Yes.
It's agreed. It's internationally non-human rights. It's actually written in the Sustainable Development Goal. Actually, a human rights, basic human rights.
Well, do the governments where you have worked, they do understand that this is a right of every single citizen in Sudan to be treated? Do they know that?
If they don't know that, they have to know that.
Okay, come on. We have to move. Okay, thank you very much, Abdelrahman. Okay.